there are 3 therapies that have now been FDA approved for treatment of NMO. These are targeted treatments. One of those treatments, Inebilizumab, had presented data in terms of long-term safety and efficacy of this product, and the data looked very robust. We had previously presented the results of the randomized controlled trial, which was only about 6 months in duration. And now at this meeting, we're presenting data that goes out all the way to about 4 years. And we see that there's a durable therapeutic effect of the product. And if anything, the drug looks like it gets better and better over time. The majority of the attacks that do occur within the first 6 months of treatment, up to about a year. After which attacks are extraordinarily infrequent. If you look at the annualized attack rate after 6 months of therapy, it's only 0.06. This amounts to about 1 attack every 20 years or so. So because this is a very effective drug and has a durable therapeutic benefit over time, we're very pleased with these efficacy results. Other studies that have been done with this product that were recently published also showed an impact on disability. And we also showed very good safety data of this drug. We didn't see much in the way of additional safety signals beyond what was already recognized in the first 6 months of treatment, and that's very encouraging. So there weren't any unusual safety signals that occurred with long-term treatment. But one thing we did notice is that there was a gradual decline in the serum IgG concentration. This is something that happens with B-cell depletion, well-recognized phenomena associated with rituximab, another B-cell depleting antibody. And with Inebilizumab, because it hits an even broader range of B cells, including the Cree B cells and plasmablasts, which may be part of its better mechanism of action, if you will, we would expect to see even greater declines in IgG over time. And sure enough, we do see a decline. In the context of this study, that decline in IgG was not associated with risk of infection, but I think this is something that we're going to have to keep our eyes on and be well aware of. We know that hypogammaglobulinemia, having too low IgG, whether it be congenital or acquired, can predispose to infections. And so we will certainly need to monitor patients over time. Although it's not part of the prescribing information for this drug, because patients are coming in every 6 months, in my personal practice, what I'm doing is checking an IgG level at each of those time points when patients get infused, and using that information to guide whether patients might need supplementation with IVIG down the road, or even to consider alternate treatments, I suppose. We haven't gotten to that point, of course, yet. The drug is relatively new. We've only had it on formulary for a couple months at UCSF. But this is one of those considerations, and this is my personal method for mitigating some of that concern.